The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of those and should not be interpreted to reflect official policy or position of any entity aside from possibly Cashback Moral Hospital and affiliate outreach programs. If indeed there are any, in fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Paul, I think we've really done it this time.
That was startling. Yeah, I think so.
I think we've really done it this time. I really enjoyed this episode, and we talked about correctional medicine, what happens to people when they're in jail or prison. But Paul, before we get into that, why don't you tell them where we're recording from and what we do on this fine show?
Oh, happy to. I almost had this in the year of our Lord 2018, but we're actually at SGIM or SGIM or SGIM, depending on who you ask. But at the annual meeting, and we have been for the past 2 days been interviewing experts and going to meetings and conferences and talks and workshops. And we have a treat for you this time around. We have 3 amazing guests to help explain the practice of, I'm not even sure we sort of settled on a term, but people to take care of people who've been exposed to the correctional system, I think is the way that we came away with. But in any case, before we get to all of that, we are the Internal Medicine Podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. And then we do try to get to know the guests a little bit at the front. Don't skip past it this time because they're all especially fascinating. No, let's forget that part because that implies that we had prior guests that were not fascinating. So, but just listen, okay? Is it that hard? Just listen to the beginning.
It reminds me of remember the SNL skit with the Hurley boy? Like, it was like Adam Sandler was... No? Okay, forget it. Anyway, look up... we'll put it in the show notes.
Sure.
It's like Adam Sandler. He's like, please let me stay at your house. And then Chris Farley would just be like, just let the boy stay at your house. Anyway.
Great.
It's a great Adam Sandler Farley. And
so that's our pick of the week.
Paul, we've been recording for almost 4 hours straight. Actually, more than 4 hours straight.
Yeah.
We have with us today, Paul, and we really have to thank him. He found these 3 wonderful guests and somehow convinced them to come on our show. The great Justin Lee Burke. Justin, thank you for doing that.
It was a great show. Excited that we were able to have him on. Thank you, guys.
So why don't we get into our guest bios because we got to get on. We got a lot of show ahead of us.
Sure. Okay. So I'll introduce Dr. Jonathan Giftos. He is the Clinical Director of Substance Use Treatment for the Division of Correctional Health Services at Rikers Island, where he oversees diversion, harm reduction, treatment, and reentry services for incarcerated patients with substance use disorders. He is also the Medical Director of the Opioid Treatment Program for the New York City jail system, in which he also provides clinical care, including the provision of methadone and buprenorphine maintenance treatment to incarcerated patients with opioid use disorders. He remains closely affiliated with Montefiore and the Primary Care and Social Medicine Residency Program, and currently serves as a volunteer attending in the Bronx Transitions Clinic at Montefiore's Comprehensive Health Care Center in the South Bronx. Dr. Giftos advises cities and states around the country on the provision of substance use treatment in correctional settings, and has partnered with Physicians for Human Rights to advocate for evidence-based treatment for patients with cases before drug courts.
Our next guest, Dr. Emily Wang, MD, MAS, is an associate professor at the Yale School of Medicine and co-founder of the Transitions Clinic Network. Dr. Wang's research focuses on promoting health equity for vulnerable populations. I always have trouble with that word, Paul. Especially individuals with a history of incarceration through both prison and community-based interventions. She is a co-founder of the Transitions Clinic Network, which is a consortium of 15 community health centers nationwide dedicated to caring for recently released prisoners and defining best practices for the healthcare of individuals leaving prison.
Our third guest, Dr. Aaron Fox, is an associate professor of medicine in the Division of General Internal Medicine at Albert Einstein College of Medicine, Montefiore Medical Center. He's a primary care physician in a community health center in the South Bronx and a researcher studying opiate use disorder treatment in the criminal justice system. Dr. Fox is the director of the Bronx Transitions Clinic, which links formerly incarcerated individuals with chronic health conditions in medical care. And honestly, on a note, too, for people that are interested in addiction at SGIM, a lot of the conference was like the Aaron Fox show. He did help the Criminal Justice Interest Group. He did the Update in Addiction Medicine. He helped, he was part of a symposium on mass incarceration. He led the abstracts in substance use. I mean, he was everywhere in this trip.
Yeah, we are very lucky to have these three wonderful guests, and I hope you enjoy the show as much as we did. We have three wonderful guests, as we've mentioned in our intro, and we're just going to go around the table. Let's go clockwise. Aaron, can you give the audience a one-liner and include something about yourself that you do outside the world of medicine?
Okay, my name is Aaron. I'm a primary care doctor through and through, and I also like to think of myself as a writer, but I don't think my wife has ever read more than a paragraph of my work without falling asleep.
Okay. Are you writing? Are you doing medical writing, or just are you sort of writing fiction or poetry?
Nonfiction stuff.
Okay, cool. All right, Jon.
Hi, my name's Jon Giftos. I am a doctor working in the New York City jail system for New York City Health and Hospitals. Outside of work, I have two young kids. I just had a son in November, and they take up all of my free time.
Understandable. Okay, congratulations. And Emily, how about you? One-liner and something outside the world of medicine. What's taking up all your free time?
All right, so I'm Emily Wang, and I am a physician, researcher, and I'm obsessed with decarcerating our country. And I would say what takes up a lot of my time is a family that I'm raising in Mandarin, Spanish, and English.
Oh, so impressive.
I don't know how impressive it is.
To be honest, your English is not that great.
Most days.
Yeah, I think that's great. That's great. How are do the kids like it? Like they're not like...
They don't have a choice.
They don't have a choice. Okay.
Do you have kids? I mean...
I've tried to speak to them in Spanish, and they're just like, stop speaking to me that language. I think they'll learn the utility of it. Okay. Paul, Justin, did you guys want to ask any questions?
I think I heard there were book recommendations. So
Okay.
during the pre-recording. So I'd love to have a book recommendation from each of you, if you don't mind.
Yeah, well, I just finished a book by Homer Venters, who was the chief medical officer in the New York City jail system, and wrote a book, Life and Death in Rikers Island, where it goes through a bunch of the high-profile deaths that when he was working at Rikers Island that they had to deal with, and it goes through some of the issues that led to those adverse outcomes, including lack of transparency in the whole system and lack of surveillance for health problems that were coming up.
So Homer Venters actually was one of the docs that recruited me to work in the jail system, and he's a real leader in this work. Having two young kids, I mostly am reading like the Gruffalo and books like that. But on my drives to and from Rikers, I started listening to books on tape, and I'm currently listening to the Power Broker about Robert Moses, and it's all about the sort of way the city was designed over the last 60 years. And I think it's like an 80-hour audio book, but it just gives a tremendous historical overview of how neighborhoods were carved up and how public housing was built, and that so much of the struggles we face in New York right now are due to very concrete decisions that were made by people in power many years ago.
There's an amazing article, I'm trying to remember where I just read it, that looks at sort of structural racism based on sort of housing and how it was allocated like a century ago, and how that still correlates to gun violence in present day. And so how some of the structures that have been in place for decades at this point are still resonating or still causing the issues that we're running into. That's fascinating.
Emily?
So, book recommendation. So if there's one book around incarceration, I mean, I think it's an incredibly powerful narrative, either on tape, like you can get it on Audible, or purchase it. It's Brian Stevenson's Just Mercy. It's beautifully narrated, really compelling about his work as a lawyer pushing for death penalty reform in Alabama, which will be the site of next year's SGIM. So that's the book. And then recently in the New York Times, a beautiful long piece form on Ruthie Gilmore and thoughts about abolition, what it means to take down a carceral state, and how do we build a social system and structure that really kind of puts health and well-being at the fore. So New York Times, 2 weeks ago.
Great.
Yeah.
Those are good directs. One of the questions, a lot of our listeners are learners, either residents or medical students. Can you share a piece of advice that you got at some point in your career in medicine or addiction or correctional health, but something, a good piece of advice that we can kind of share with others?
Well, I think my mentor gave me the same advice over and over and over, and I didn't listen, and I regretted not listening, and it was to focus. That I think taking on too many responsibilities during residency, during fellowship, you want to constantly be pushing yourself, and you don't want to close doors to new opportunities. But then at the same time, if you spread yourself too thin and you can't actually finish on projects that you've started, it really, the quality of the work suffers, and it's not even worth starting it from the beginning.
I think one of the most important things that I've been reflecting on lately is just this this idea that to talk less and listen more. I think we, especially as like a white man in the space with a position of power, I think when I'm in rooms, I can sometimes be given a large platform to speak, or I can take up a little bit too much of the oxygen. And so I'm trying to just be sensitive to, the fact that we should be, listening more. And I think that's true clinically too, right? There's a lot of good, sad studies that have shown that we interrupt patients very quickly early in encounters. And I think just taking a moment to listen, despite how busy and chaotic the day is, I think is some of the best advice that I struggle to put into action.
That's beautiful. So I'm a med school advisor, and I appreciate the question because I think I often get this question a lot. I think medicine as a field often kind of can track us and push us into really normative decisions. Like I'm going to become the best pediatric gastroenterologist that does endoscopies, et cetera. And, for me, a lot of my passion for this sort of work started in medical school. And you can often get the messaging that the paths that move you forward are not normative, they're not traditional. How can you make a career in this? And I would say that the three of us and the communities in our tribe that kind of fill us are testament to the fact that you, in fact, can make a career out of this, is to find that which motivates you, to not lose that joy and push forward. And I think in particular for young learners and then people of color and women in particular, that these systems that are often inhabited by white men and the hierarchies that exist and have come before us can often script narratives that are convenient and traditional and normative for them, and they just don't have to be. So that's the advice that I would give, is just to find that deep joy, struggle on, and find people that support and fuel you.
Fantastic. I think we should move on to the topic here. And Justin, I'll let you take it.
Let's dive in. Well, maybe I think because this is a little bit of a unique issue for us, can we have one of you, and maybe Emily start, just talk about incarceration and how this has systemic health issues. Like, why is this a public health issue? Why is this something that should be in the realm of internists? How is this a component of healthcare?
I think that just as a starter, and I think it was a shock to me when I first learned this, is that our country incarcerates more people than any country in the world, more people than any kind of developed democracy, Russia, China, period. And what it has happened is that in the past few decades, 3 decades, the rates of incarceration have increased in spite of profound decreases in violence. And so we have an appetite for having incarcerated, and it's a systemic issue. It isn't a singular issue. It isn't one that's driven by the left or the right. It is an issue of our country. And in that, in particular, what is notable is that we disproportionately incarcerate certain populations. So we disproportionately incarcerate racial minorities to the point that the data suggest, at least from 2003, and then it's been repeated, that if you're a black man living in this country, you have about a 1 in 3 lifetime risk of being imprisoned. And this doesn't account count time in jail. This is imprisonment. And that racial disparity bears out for Latinos. It also bears out for women who are among the fastest growing population behind bars. And so there's a significant disproportionate bias in whom we incarcerate. It's along racial lines, and it's also along socioeconomic lines, right? And so we incarcerate poor folks of color. And in doing so, then have subjected them to systems, places, people that are increasingly and certainly toxic. And so, they're pushed into a jail or a prison, away from their family, away from the social supports and structures that they have. And, as we'll talk about today, that has bearing for their individual health, their family health, and their community health.
I think it might be helpful. We talked a little bit before recording to actually get into the language too, because you mentioned imprisonment being different than jail, and then also just sort of how to talk about this patient population in general and sort of what type of medicine that we're talking about. Would you mind sort of going through some of the terms that we should be using and hopefully using correctly during the recording?
Sure. These are, it's a complicated landscape, and you're not taught this stuff in medical school, and most people never learn, the various entities involved in the criminal justice system. But I think that there's many different ways to be under what we call correctional supervision or correctional control. It could be anything from a jail, which is where people go when they've been arrested and charged with something, and they can't afford bail to go back into the community. They may be detained in a jail. They may also serve a short sentence in a jail, usually less than 1 year. People who've been convicted on felonies are generally transferred into prisons, whereas jails are marked by flux and chaos and a churning population. The median length of stay in New York City jail, for example, is about 2 weeks. Prisons are where people go to serve sentences, generally more than 1 year. Most people in this country are in state prisons, not federal prisons. And that has been a large growing population as well over the last 20 years. People who are in prison and then they are released to the community sometimes are done so on parole, which is an extension of your sentence into the community. You're under supervision of a parole officer, and you can be sent back to prison if you don't, adhere to the conditions of your parole. And then probation is this sort of, fourth type, which is generally in lieu of incarceration. People are placed in some community supervision status. The key similarities between parole and probation are that these patients are at high risk if they struggle with a substance use disorder, if their life becomes chaotic and they fall out of line, so to speak. They can be sent really quickly back into correctional settings.
Can I just jump in and summarize a little bit? I think an important way to think about why incarceration matters for healthcare is because it's common, as Emily was talking about. Years ago, residents interviewed patients in our community health center, and 50% of the people who were interviewed reported that someone in their family had spent time in jail or prison. Chronic health conditions are common among people who are in jail or prison, that every chronic health condition that we take care of is overrepresented in people in jail or prison. And something like chronic infectious diseases like HIV or hepatitis C are at least 3 to 5 times increased prevalence in that population. Something like substance use disorders, it's estimated 2/3 of people in jail and prison meet criteria for substance use disorders. So it's incredibly common. But additionally, we also think that exposure to the criminal justice system itself is toxic and it contributes to worsening of people's health, both through the disruption in people's lives in medical care, but also the exposure to violence, the exposure to solitary confinement, the social isolation that people experience when they come home from jail or prison.
And the patients that are the individuals that are incarcerated and have these chronic conditions and have comorbid substance use and presumably mental health challenges, how are those addressed in jails and in prisons? Is the healthcare, who's providing the healthcare? What type of healthcare are they giving? And can you guys talk a little bit about that so we know when patients are back in the community, what the contrasts there are?
Healthcare in correctional settings, I think, is really heterogeneous, and it varies all across the country from city to city and state to state. And, that heterogeneity is really challenging because it's not a particularly well-regulated space. There's not correctional health systems don't bill insurance typically, so they don't have the same oversight from payers that you might see in the community. And some parts of the country, because correctional health is funded by municipal or state dollars and not insurance, people will invest less or more in the healthcare services. As Emily mentioned in the previous session we did, there is a constitutional right to healthcare, but the quality of that healthcare and what it means can really vary a lot. Just to give one example of, in the New York City, for example, the city public health system, the city public hospital system provides healthcare in the jail system. And that allows the healthcare delivery there to be more integrated into the city's larger, public hospital system. But that's not the case in many places.
A very specific question, but does that mean there's medical record communication that way? I think sort of one of the transitional challenges is actually sort of obtaining any past records for patients. It's easier to talk about patients with the larger system. You can share information more easily. What's interesting is many correctional health systems don't use electronic health records. But that we do in New York City, which is important, but many places don't use electronic health records. Many doctors in correctional settings don't have internet access. You can imagine, how often we rely on UpToDate and things like that, and so they're really isolated, and correctional health is isolated from community health in ways that I think has perpetuated a lot of the problems.
What the conditions that we talked about a little bit, substance use disorder, chronic infections like HIV, and mental health care, are patients guaranteed? Let's say someone has HIV and they get screened when they come into the prison system, and will they be started on ART and will that be continued? What happens when they're in there? I never really learned about this before.
So I can speak to one particular system, but I'd be curious to hear. I know Emily's worked in other systems, and I'm curious what happens in Connecticut. You have to pay for all of these services with your municipal or state dollars, and so and a lot of what happens in correctional health has been driven by litigation and lawsuits of being denied access to things. Mm-hmm. But for example, if you come into the New York City health system and you're on whatever medication you're on, there'll be an effort to continue it. But in some parts of the country, they don't screen for hepatitis C, for example, because you're screening for something that you don't want to treat yourself because it's too expensive.
Right.
Yeah.
And so you saw similar things, I think, with HIV as well. There was not screening routinely for HIV because the systems didn't want to pay to treat the condition that they've diagnosed.
Do you think most patients in correctional facilities, are they getting treated? Emily, do you know? Is there data on this? Are they for HIV? It must be cheaper now to treat that than Hep C at least.
So the data that come from the Bureau of Justice Statistics estimates that the majority of individuals do see a physician when they're incarcerated and also are started on some medication as needed. So, broad strokes, and I appreciate Jon's comment that there is real heterogeneity across the system. Just because you see a doctor doesn't mean that you've met any of your health needs, really, right? And that they're not attended to in a ways that satisfy you and your health issues. And so, but the Bureau of Justice Statistics, at least, which is a federal survey that's run across prisons and jails, estimates that the majority of individuals do see a physician when they're incarcerated. It is different, again, distinguishing between jails and prisons. So the rates are a little lower in jails than in prisons when people are incarcerated for longer times. I just wanted to back up into a question that you raised, about a patient with HIV. And so I think it's important, when thinking about the folks who we incarcerate, that oftentimes once they're incarcerated, this is their first time accessing healthcare as an adult. That many of these individuals have never accessed health care, either because they're uninsured or they're young, presumably, they think that they don't have any health conditions, they don't go to the doctor. And so what happens is that once they've entered a correctional system, they meet a physician like Jon, they're screened for some chronic or infectious or non-communicable diseases, they're newly diagnosed with that HIV disease, right? About 40% of individuals that move in between a correctional facility are newly diagnosed with a chronic medical condition for the first time once they're incarcerated. And so their whole experience of that chronic condition, HIV, opioid use disorder, hypertension, you name it, is impacted by this health system that we almost never see as trainees, students, providers, et cetera. And it's this whole network, this whole health system that's out of our sight as community providers. And it's in that system that oftentimes actually the data are quite compelling, that viral loads actually do get suppressed, CD4 counts do improve for people with HIV. That said, the studies are prominently coming out of certain health systems. And again, so it just speaks to the heterogeneity across health systems. I will say that for those who are incarcerated, I don't know if any of you have gone into a prison or jail before. Have you? Great. So just a few of you. If you see kind of how care is delivered, what you're going to see mostly is that people are woken up at the crack of dawn. A correctional officer wakes you up. You go and make a med line where a nurse gives you your pills. The pills, are poured out in a cup. If it's your hydrochlorothiazide, your amlodipine, your tenofovir, whatever it is, you down this cup of water. They check to see if you've cheeked it. You're escorted back to your cell. And so the care is incredibly passive. You don't have to think about it. It's there. You don't call a pharmacy. You have to access your meds. You don't need to know what you can eat and how you can eat it. None of that, because it's all scripted. Adherence is really high. And so the data show that actually viremia is well controlled. CD4 counts do improve when you're incarcerated, right? And so that's the system of care. And with the huge caveat is that there's lots of heterogeneity across. But again, it's a system that's passive. It's a system that doesn't ask for the activated patients, that really knows how to manage their HIV disease, high blood pressure, diabetes. It's a system that if you're an insulin-dependent diabetic, you never have to inject your insulin. You never have a glucometer on hand. And so it's one where there's very little self-efficacy, very little that's asked of a person in terms of how they manage their own chronic condition.
Can I just bring up? I mean, the one situation which is really striking where people don't have access to medications is medications for opioid use disorder, where there's very few states in the United States where people are offered the gold standard treatment for opioid use disorder, either methadone, buprenorphine, or extended release naltrexone, one of the 3 FDA-approved medications. So Rhode Island State Prison, Connecticut State Prison, now New Jersey is offering medications in prisons. But the standard across the United States is that if someone has opioid use disorder, they're incarcerated, even if they were taking buprenorphine. One of the brand names that's commonly used is Suboxone, if people aren't familiar with buprenorphine, naloxone. If people were in a methadone program, or if people were taking buprenorphine, then those medications are taken away from them. They have rapid periods of managed withdrawal, or what people call detox or detoxification. And there's this sense that, well, if someone has a long prison sentence, then they're better off because then they'll have all opioids out of their system. But it's really this misguided approach with this assumption that incarceration is going to cure someone's addiction, which just isn't what the data bears out, and isn't what we see in real life. So when people are released from prison, when people are released from jail, the risk of resumption of opioid use is dangerous. In that setting, people have lost physical tolerance because it's common to continue to use opioids within correctional facilities, but people aren't using as often as they previously were. So then when people come home, if resumption of substance use is high, and some studies, if you look at it, more than 75% of people with opioid use disorder will start using again within 3 months. And then if people go back to using the same amount of opioids they were previously using, the risk of overdose is incredibly high. So big studies have demonstrated consistently in the United States and other countries in jail setting and prison setting that the risk of death in the 2 weeks following release from incarceration is 12 times elevated. And then specifically for drug overdose is more than 120 times elevated in the 2 weeks following release from prison. So this is something where the standard policy that's accepted across the United States is extremely dangerous.
And it seems like such low-hanging fruit too, right? Because I think you mentioned the data seems pretty robust in what treatment can do while in correctional facilities. My understanding, if you start someone right before discharge, you have a much lower chance of having relapse of your opiate use disorder. You have a much higher chance of kind of maintaining outpatient treatment. Is that?
Yeah, so I oversee the opioid treatment program in the New York City jail system, and we have been fortunate to have since the 70s, early 80s, we've had methadone maintenance available to incarcerated patients, and buprenorphine has been available for the last at least 10 years or so. And there's, I think Aaron referenced this, but there's good international and now local data out of Rhode Island that shows that exposure to agonist therapy while you're in correctional settings is associated with about a 75% reduction in post-release mortality. So it's a pretty substantial reduction. Yeah. So we and just to sort of Emily's point, we have about 70. So we have in New York City, there's, thousands of people that pass through the jail each year with an opioid use disorder. The prevalence is probably about 15 to 20% of the total jail population. And 75% of people enter off any treatment. About 20% enter on methadone, 5% enter on buprenorphine. And 80 to 85% of people leave on medication. So it's a place where people have access to low barrier agonist therapy. But it is not as easy to access those treatments in the community. And so everyone, will say, oh, it's such a great that you're able to provide those treatments in the jail. And I always sort of get frustrated at any framing that thinks that a jail is a place to deliver a therapeutic intervention. We do it because they're there and because it saves lives and because we think it's the right thing to do. But we really would never want anybody to take home from this that jail is a place to kind of design or to implement these interventions.
And Aaron, I think you'd mentioned there is health toxicity associated with being exposed to sort of the correctional structure. Is that because of these transition points, or were you referring to something else?
Yeah, I think that's one of the toxicities that we worry about. It hasn't come up yet, but one of the things that I think all of us are very concerned about is exposure to solitary confinement. That we, in the Transitions Clinic Network, we did a study where we were screening people for post-traumatic stress disorder when they came home from prison and entered the clinical model for primary care. And among those patients, we saw that people who had been exposed to solitary confinement were 3 to 4 times more likely to screen positive for post-traumatic stress disorder than those who had never been exposed to solitary confinement. And that just really reflects what I see from my patients, that people are coming home with symptoms of hyperreactivity, of vigilance, of fearfulness, not wanting to be in public places. It makes it hard for people to seek care and to come into a busy community health center. So the overuse of solitary confinement in the United States is really something that's what I would consider a toxicity. And then also at Rikers, they've done research as well, looking at exposure to solitary confinement in episodes of self-harm, when people try to hurt themselves, or suicide attempts. And it's really tightly associated with the timing that someone is scheduled to go into solitary confinement. So people will harm themselves to avoid solitary confinement. People will end up in solitary confinement and then harm themselves to get out and then go to the infirmary. And it doesn't really matter whether it's a real suicide attempt, or what they would say, well, people are just using it to manipulate the system. The fact of the matter is, if someone does something dangerous, like swallowing caustic materials, in Dr. Venter's book, he talks about a case where someone swallowed a soap ball and ended up corroding his esophagus, and he died because he didn't want to be in solitary confinement. He had a mental health problem, which was exacerbated by that situation. And when he called for help, nobody responded. So this is also something that certainly exacerbates people's mental health conditions, but also even people without chronic mental health conditions can also cause harm.
Emily, when we were in pre-recording, Aaron brought up that he really admired the way that you brought up how you should ask a patient about incarceration. So could you share that? I think that's a really practical thing you could share with our audience.
Yeah, I'd be happy to. I mean, I think, hopefully we've made the argument that it's a really common condition, experience for people that you see in primary care, you see as internists. And so I think the important thing to highlight is that we should be systematic about it, that we should be asking everyone about it, given how common it is. And then we should ask it in a way that's not biased, right? So that there is so much discrimination and stigma around incarceration, to be very careful and cautious with how you ask. So the standard way I ask, and I ask it in our social history section, where you're really digging into things that you say, I ask this of everyone, but these are kind of sometimes tough questions, is have you or any family member ever spent any time in jail or prison? I ask that without bias to all my patients. And what I have found over time is that it's important as a launching point of understanding kind of their own management of their chronic conditions, why they've been absent from care, why they may have concerns or mistrust issues within the health system. It's an opening space to also then talk explicitly and actively about, look, we think one of the most important things for keeping you healthy is not having you go back in. So what can we do to prevent you from going back in? It does not mean that we want to know that person's crime. I mean, I think among each and every one of us, we have deep fears, notions about criminal behavior, what is right, what is wrong. All of us have those real deep biases given where we live and who we are. And so this is not a place to say, I'd love to know what you committed, how you committed, but it is a place to say that we're here as a healthcare provider to think about how it is that we keep you healthy. And so there are really kind of productive launching points to then say, how do we keep you out and home?
So I'll actually say, a lot of our episodes, we have case studies that have a funny patient's name that's like a pun. And I feel like this is almost a little more of a somber tone because of the tragedy of kind of the issues that we're talking about. But to bring it back to a specific patient or a specific case, if we had a 34-year-old gentleman who has hypertension and diabetes or has kind of some chronic health issues, was recently incarcerated, coming to the clinic, can you guys speak about what are some of the unique challenges of patients that are post-incarceration, or what they might be at risk for, or things that we should be as primary care providers working on to improving we're taking care of them as we should?
Well, I think one of the things that Emily already mentioned about self-efficacy and self-management skills is something to focus on. When people are coming home. They may have high levels of mistrust in just the healthcare system in general, and breaking through that mistrust can be really, really challenging. And there's differences between jails and prisons. If people have a short stay in jail, it can be really disruptive and can create chaos in their life. So if they have diabetes or hypertension, continuing those medications may not be their first priority. But if someone's been in prison for 20 years and then they come home, they may not know how to navigate the healthcare system. They may never have picked up a medication from a pharmacy with a prescription. But I think the number one thing for people to be aware of is the amount of trauma that people experience, that when people pass through jails, there's high levels of violence, and people may have had traumas from that, especially women who are incarcerated may have had a history of sexual abuse when they were growing up, or even sexual assault within the jails and prisons are common. And as a clinician in the community, being able to provide trauma-informed care is really, really important. And what that means is not just the provider, but the entire staff. And sometimes I think about if somebody had a bad experience seeking medical care while they were in prison, and they're worried about being stigmatized because they just came out of jail, and then they end up at the clinic, and the first person that they see, the clerk, is just having a bad day and snaps at them, and they're expecting that they're going to be stigmatized, then they may interpret that as saying, oh my God, they know that I just came home from jail. Everybody's going to treat me like this. And then we lose people, and people are hesitant to seek care. So I think staff trainings, but also providers being able to think through trauma-informed care, what it means, the type of words that you use, the type of tone that you use, when you're preparing someone, if you're going to touch them or do a physical exam, really being attuned to the possibility that they have trauma. And this just makes me think of one of my patients when they really taught me an important lesson. Because I'm a primary care doctor. I'm board certified in addiction medicine. I do research on opioid use disorder. I'm very attuned to prescribing opioids and the risk of addiction. And I feel comfortable setting limits with patients. And one of my patients, I was trying to set a limit about prescribed opioids. And she had got a prescription from another prescriber, even though we had talked about that, well, if you're taking chronic opioid therapy, I'll be the one who's prescribing you the medication, and you really shouldn't get prescriptions from other doctors. And when I was talking to her about it, I was trying to be firm because I thought, having two prescribers can be a risk factor for problems or for overdose. And she said, Dr. Fox, you're scaring me. You sound like my parole officer. Mm-hmm. And I was like, wow, Mrs. So-and-so, I'm so sorry. But also, the fact that she was able to say that she, despite the power dynamics that are in the room, that are in the office, she still felt comfortable enough to bring that up with me, I think reflects the relationship that we had at that time. But it's also a constant reminder about the way that I talk to people.
It's a nice story.
I just want to, I'm really glad that Aaron mentioned trauma. We talk about it a lot. It gets, when we talk about trauma in the jail or prison system, I think people have something in their mind of, violence, brutality, assault, and that definitely exists. But what I also see, and I think it's important, is to acknowledge that trauma for many of my patients are things like abandonment and neglect, and that have maybe been, for big parts of their lives, and that, so that kind of trauma, grief of like witnessing violence, witnessing somebody shot and killed in your neighborhood or having domestic violence in your home, that stuff all is also trauma and can manifest, I think, in ways that complicate relationships with healthcare systems. Just to double down on Aaron's point, slow to trust, hard to make behavior change, maybe like difficulty like managing frustration or poor frustration tolerance, or those things that our system, I think, doesn't always attribute to trauma. It attributes to this person is difficult or this person is hard to manage. We would prefer you find another clinic to go to. That kind of pushing people away. And I think when you learn about the way trauma manifests in people's lives, you can start to teach your health system to better engage people who show those kind of health behaviors. And I talk a lot about the first person that people usually encounter when they come into a clinic is often the clerk. It's not the doctor. So you could train doctors all day long about being warm and non-judgmental and using person-first language, but if the person doesn't even get into the exam room, you're not really able to care for that patient. And so I think we could do a lot more to sort of work with our front desk staff and our receiving staff, the people that answer the phones, et cetera, to kind of have more sensitivity around some of these complicated issues.
The other thing I might add to this is that for the patient that Aaron saw and the patients that I see, each and every day, it's the health system that presents barriers, but also we have larger systemic barriers for these patients that have histories of incarceration to meet basic needs. And specifically what I mean are the hundreds of thousands of collateral consequences that exist after a person's released from having served their sentence in a jail or prison. And state by state it varies, but this ranges from having, in my home state of Texas, a lifetime ban if you've been convicted of a drug felony to getting access to Section 8 housing or food stamps. It's a lifetime ban. In certain southern states, you have a lifetime ban to voting, a fundamental principle of our democracy, and you've lost the right to vote. And so what it connotes to the person coming home is that you're not their citizen. It connotes to them that actually you've served your sentence, but we're going to still have you serve more. And if you think about kind of what we do as an internist, and we're in this big push of understanding that we have to meet people's social needs and what are these, quote unquote, social determinants of health, that incarceration presents additive barriers to actually meeting the fundamental basics of housing, food, reintegration with patients' families, employment. And so, again, there's these large systematic barriers at force, state by state, that really constrict our ability to provide meaningful health and health care.
I was going to ask you about transitioning. Do patients get... It sounds like probably when patients are getting discharged or released from prison, they're probably not thinking like, I got to get to my primary care doctor within a week. So it sounds like they're probably thinking about, what am I going to do for housing and work and, to feed myself, let alone like, how am I going to pay for my insulin or my medication for hypertension? So it just sounds, it sounds like a very challenging situation, but what efforts or what exists, if anything, to get them connected? Like, do they get paper records on the way out the door and say like, here's your medical records, so you can at least see what meds they were on while they were there?
So I think one of the most profound kind of criminal justice reform policies that we've seen in the decade is the expansion of Medicaid through the Affordable Care Act. And so to me, states that have expanded Medicaid, that probably is the single largest criminal justice reform policy there's been, whereby now young adult men that are without children actually formally for the first time have access to Medicaid. And so this enables them the ability to at least pay for the basic services that Medicaid in their states have. So that's huge. Certain states, certain jails, state prisons and certain jails do have a discharge plan, and it's variable. In, again, my home state of Connecticut, what they have is a voucher program that people that once they're released from prison, they get 30-day supply of a medication. But as the literature indicates, many people actually, with that voucher, it's just not enough. It's just not their highest priority. If they don't know where they're going to live, how they're going to feed themselves, then they're not rushing over to CVS to get their voucher, right? So there are discharge structures in place and also kind of larger policy measures that have been passed to really bridge that gap. One of the things that we've been able to do through the years is build upon a network that puts patients' priorities, their values, and their preferences first through Transitions Clinic Network. And it was through conversations with real leaders, formerly incarcerated leaders, that we thought about how best to make our healthcare system within the community more responsive to their needs, really realizing that transitional period is a very vulnerable time in an individual's life. And so created a model of care, hopefully, that is responsive to these needs, whereby we hire people with histories of incarceration to work in the health system as community health workers. And it's that community health worker that I think bridges much of the mistrust that we talked about, starts helping the individual build self-efficacy skills, helps them just like as a person to call on. Like once you're released, you're feeling isolated, it's lonely, you've come home after 30 years and you're like, I don't even know what this, what's the World Wide Web? Right? So that kind of business, that's a person to call up and then actually be able to connect with. So the community health workers embedded within primary care, working alongside primary care physicians like ourselves. And it's that connection, it's that interdisciplinary team that actually, I think, provides a transition home for again, these 2.2 million people that are incarcerated in jails and prisons.
I was just going to ask Emily, in New York, the community health worker that we have worked with the Bronx Transitions Clinic was associated with Osborne. And so the Osborne Association as a reentry organization had so many additional services to support people as they're transitioning. Is that the case in the Transitions Clinic all around the country where the CHW is also a part of a reentry organization?
No, each transitions clinic program is really built upon the assets that exist within the community health center and the cities or, and neighborhoods in which they're situated. So the Bronx Transitions Clinic program has an amazing, Aaron's better suited to talk about this, an amazing community health worker that was based in this reentry organization that provides and attends to all these social determinants, employment needs, housing needs, legal needs, et cetera. Each of our transitions clinic program, however, does partner with community-based organizations that do attend to these social determinants of health, and that's a huge piece of what we do. It's that, we contend that these are equally as important, if not more important, than getting your script for your insulin, right, and learning how to use a glucometer. And so that's a key component. The other component is just to transform primary care, right, is to create spaces within primary care that are trauma-informed, that provide open access care, that really say, look, we're here for you when you need us to be here, not when the doors are open. And so, again, transitions clinic programs are based within community health systems and often structured in ways that aren't as patient-friendly. And our community health worker then enables us to be able to provide care where our patient's at versus within the community health system.
Aaron, anything to add?
Well, usually when I talk about our transitions clinic and the barriers to care that people face when they're coming home from jail or prison, emphasize that as a healthcare provider, just having an uncaring demeanor can send the message that you don't really care about your patient, and then people don't come back. And it's been published in the literature as a barrier to care. And something as simple as that, I was fortunate to work for years with, I would work on Saturdays, and we had a walk-in session to make it easier for people to come into the clinic because there was less people at clinic on Saturdays, and they didn't have to wait in a busy waiting room. It was open access, so we didn't have to worry about people showing up late or missing appointments. But also, I worked with this lovely nurse, Ms. Diaz, who really our patients loved. She had this just warmth to her, where when people came home from prison, she wasn't judging them. She was just really showing all of our patients love. And I think that was such an important component, in addition to the community health worker building trust and having providers who did have some knowledge about care for best practices for people who have criminal justice involvement.
Well, I don't want to take more of your time. So any burning questions before we maybe get an ask or a plug they can...
No, I wanted to ask, hopefully this isn't too broad. This has been tremendously inspiring and I think a great entry point for this issue. I guess I'm wondering, for our listeners and for me selfishly, what are good resources to learn more about sort of how to provide this type of care, and also, and just even in terms of advocacy, where do you kind of start? Because it's just such a big topic to wrap your hands around.
There are national organizations that are dedicated to correctional health, and I think Aaron and Emily could speak to those. Is the American ACCJH? Is that what it is? I'm bad with the acronyms. There are some good,
Sure.
national organizations, but I was actually, before you jumped to that question, I was going to say, just if I had to say one thing, that is that most people, wherever they're practicing, don't have really a clear sense about what the correctional settings are like in their city or state. Who delivers healthcare there? What would you do if you had a patient that was detained and you wanted to share important medical information? What are the points of contact? Or to visit. And I think, there's a great Nelson Mandela quote that I'll butcher, but it's basically, if you want to understand a nation or really see a nation, visit its jails and prisons. I think going inside correctional settings is incredibly important to understand what our patients experience and how healthcare is delivered. But I would just make a plug for trying to work with your local public health office or your community leaders to try to understand better your correctional settings in wherever you may work, so that you can understand perhaps how better to partner, or whether you can some people may work there and try to improve care there. I think that to make correctional health a part of community health and to try to break down some of those barriers. And it's really, because it's so different across the country, there's not really one piece of advice as how to do that. There's 50 county jails, for example, in some big states, and each has its own leadership and healthcare delivery system. But just to we are pretty good at tracking down information when we need to for our patients, right? That's what we did as interns. And,
Sure.
So kind of being a little bit like a detective and trying to figure out how to learn more about your own correctional health system, I think is a really important for everybody to do.
So the acronym ACCJH is the Academic Consortium on Criminal Justice Health, and they have developed materials for curricula on criminal justice and health and for best practices. I think I also know if people just Google, the Fortune Society put out a pamphlet for caring for women with criminal justice involvement, women with HIV. And in that pamphlet, there's some of the language, some of the stigmatizing language to avoid. So I think that can also be a good resource just to look through and understand a little bit about trauma-informed care, how that informs some of the best practices and some of the words to avoid. And for medical people who are interested in the epidemiology and the research, they should look at Dr. Wong's research. She's done a lot. She's done a lot of the most important work in this field, and she's probably too humble to bring it up, but had a paper in Lancet, which she can give the reference for, which I think is a really good starting point for understanding both the scope of mass incarceration, the direct impact on health, and then some of the other indirect effects on healthcare delivery with Chris Wellman.
Yeah. So we published it in Lancet last year as part of a series of papers that came out in Lancet looking at inequality in the U.S. And so, last year, 2018, Chris Wilderman and myself. Thanks. So I would say as a resource, as a place, I'm going to pitch a med student endeavor that I think has been great. They have a monthly kind of digest of the key articles that are focused on criminal justice and health. It's called Just Health, and it's great. I mean, I think that energy, that spirit it reminds me it's that students, residents, and fellows really are going to lead us out of this mass incarceration that we've created, So that I would turn your attention to that. It's great summaries, really pithy, and right on about their digest of what are important research articles.
And dare I say Twitter?
Tell us your Twitter handle.
Not to pitch it, but there's really I've found that to be a space where there's a lot of discussion around some of these issues, and it's actually how I connected with Emily, I think, and it's just a lot of learning to be had there.
Aaron, are you on Twitter?
Yes, ADFOXMD. And I tweet a lot about opioids and the criminal justice system and some of the science that informs some of the things that we've been talking about today.
Jon, Jon Giftos, Giftos, MD. That's my Twitter handle, yeah.
Okay. Emily?
EWANG 422.
All right.
And we'll have them in the show notes, too.
Yeah. All right. This is so fantastic. Thank you.
Great. Thanks for the opportunity. This is great.
Really
Thank
great.
you.
Appreciate you guys.
All right, Paul, let's do an outro.
Here we go. This has been another episode of The Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Just better every time. Get show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
And we're committed to providing you with high-value, practice-changing knowledge. But to do that, we need feedback from you, the listeners. So please subscribe, rate, and review the show on iTunes. Send us an email to thecurbsiders@gmail.com. And I'd like to especially thank Justin Lee Burke for writing and producing this episode, and to anyone else who helps out in post-production, to be determined. Probably Nora Taranto, who's also
She's
sitting
already
with us
on
here.
it. Nora's killing it.
Nora is always killing it.
What a star.
Yeah.
All conference long, she's been crying.
Unbelievable.
Yeah. I think it's Nora killing it Toronto. That's
Oh,
right.
yeah, there it is. There it is.
Yeah, so you should keep that as your, physician name when you finally get your degree.
Yeah. And thank you to our whole social media team, Hannah R. Abrams on Twitter, Beth Garbs Garbatelli on Instagram, and Chris the Chew Man Chew on Facebook. Until next time, I've been Dr. Matthew Frank Watto.
I've been Dr. Justin Lee Burke.
And I remain Dr. Paul Nelson Williams. Thank you and goodbye.